السلام عليكم ورحمة الله وبركاته. معكم أحمد الحماد. Inshallah, we'll be talking about stroke. We'll be focusing mainly on the clinical presentation and localization of the lesion, depending on physical exam findings. We'll go through the levels of localization in the central nervous system and the characteristics of each level. So we will begin with the blood supply to the brain. Brain blood supply is derived from two main circulation. We have the anterior circulation and the posterior circulation. The anterior circulation is mainly derived from or coming from the internal carotid artery and giving two main branches of the brain to the brain. We have the middle cerebral artery and the anterior cerebral artery, while the posterior circulation is coming from the vertebropapillar system and giving the brain multiple branches. The main ones are the posterior cerebral artery and the basilar artery and its branches, small pontine branches, and we have the superior cerebellar artery, and we have the anterior inferior cerebellar artery, and from the vertebral artery we have the posterior inferior cerebellar artery. So here we can see the brain from its two sides, from the medial and lateral sides. As we notice here in the medial side, the ACA is supplying most of the area, while on the lateral side, the middle cerebral artery is supplying most of the lateral surface, extending from the frontal lobe up to the part of the occipital lobe, involving also the temporal area as well. While the posterior cerebral artery is mainly supplying the visual cortex and only a minor area from the upper lateral, parietal, and lower inferior temporal lobes as well. السلام عليكم ورحمة الله. معكم أحمد الحماد. Inshallah, to begin our talk, we'll go through so here we can see the brain from two different views. We have the medial view. So we've been talking about the blood supply to the brain cortex. Now here we can see this Brodmann's areas distributed throughout the whole cortex. So each lobe of the brain has different areas, different functional areas. So for example, the frontal lobe, which is limited posteriorly by the central sulcus here, has the primary and secondary motor areas, which are responsible for the motor function of the body. Has this Broca's area, which is responsible for the motor parts of the language, and the frontal eye field, which is responsible for parts of the eye movements as well. And it has the prefrontal cortex, which is responsible for the concentration, decision making, and judgment, as well as the human behavior in general. For the parietal lobe, the sensory input, analysis, and recognition all done within this primary and secondary motor sensor cortices. And the temporal lobe is responsible for the auditory input. So we have the 41, 42 areas for the auditory cortex, and we have this vernix area, which is important for understanding the auditory inputs here. So without vernix area, a person can hear voices but cannot understand them, and may respond in different questions. For example, you ask him, what's your name? He says, I'm 18, for example. So the answer is not related to the question because he does not understand. Yes, he hears, but he does not understand the speech. And the occipital cortex, we have the visual cortex. Our occipital lobe, we have the visual cortex, which is responsible for the visual inputs, analysis, and recognition as well. So after we talked about the brain anatomy and the functions of the different lobes of the brain and the arterial supplies to the different lobes, now we'll start talking about stroke. Stroke can be divided into too many types. One of the classification systems is the cortical-subcortical classification, which is based on the presence or absence of the what we called cortical signs. So cortical signs are signs that are specific to the presence of cortical infarction in any of the brain lobes, which are aphasia, usually if the dominant hemisphere is involved, either the frontal in the Broca's area or the temporal in the vernix area involved, and neglect, which is the visuospatial dissociation, as we know, the usually in the non-dominant hemisphere. As we know, this is the visuospatial awareness is generally a function of the parietal lobe. So infarction in that lobe may lead to neglect syndrome. And also agraphia, acalculia, or alexia. These are called the cortical senses. The patient may be unable to read, which is called alexia, or unable to calculate simple mathematics, like which is called acalculia, or agraphia if he's unable to write. So presence of any of these signs is suggestive as that stroke is involved in the cortex, and depending on the type of these signs, you can differentiate which lobe is involved. So cortical strokes generally can be divided into the three main arterial supply to the brain: the ACA, anterior cerebral artery, the MCA, middle cerebral artery, and the PCA, the posterior cerebral artery. And that being said, we have to know that MCA is the most common artery involved in stroke patients. Now, subcortical strokes will be discussed in different videos, and generally can be divided into lacunar syndromes or lacunar strokes and the brainstem strokes. Each one has its own presentations and signs and distribution of the motor or sensory involvement. Now we'll start talking about the cortical stroke, and we will start by the anterior cerebral artery. So the anterior cerebral artery stroke usually present with contralateral weakness and sensory loss or numbness, hyperesthesia in the contralateral side. And usually the lower limbs are affected more than the upper limbs. As you can see here, that the body representation throughout the cortex is reversed, so the genitalia and pelvic floor muscles and the lower limbs are being most medial to the cortex, while the face is the most lateral. So knowing that ACA is supplying the most medial part and only a little of the lateral surface of the brain, make you suggest that the presentation of ACA will be the contralateral weakness and paresthesia or hyperesthesia, with urinary incontinence, as the genitalia and pelvic floor muscles are represented in the most medial area as well. Plus minus the presence or absence of cortical signs. So if any of the cortical signs is present, it will suggest ACA more. But absence of cortical signs does not rule out ACA syndrome or ACA infarction. And one of the top differential rather than ACA will be the cord compression, the sensory and motor weakness with urinary or bowel incontinence is an emergency if it's involved in the spinal cord or compression to the spinal cord. So you have to rule spinal cord compression, as well as you have to consider ACA infarction. Middle cerebral artery stroke is the most common type of stroke among all other types, and its presentation can be suggested from this homunculus of the body in the cerebral cortex. As we see, it's reversed. So the arms and face is the most targeted area supplied by the middle cerebral artery. So infarction in this artery can lead to weakness, hyperesthesia, paresthesia in these areas. So the patient may present with unilateral weakness, hyperesthesia, or numbness in the arms more than the legs, as the arms are supplied more by the MCA than the legs. And also he may present with facial involvement in the seventh cranial nerve. So upper motor neuron of the seventh cranial nerve can be one of the differential diagnoses of stroke. It will be manifested by contralateral facial drop, usually in the lower half of the face, either loss of the nasolabial fold or a drop in the mouth angle. Another signs may be present is the cortical signs, and this will be dependent on which hemisphere is involved. If it's the dependent hemisphere, then it's likely to be aphasia, either receptive or expressive aphasia. If it's in the non-dominant hemisphere, it's likely to be neglect syndrome due to infarction in the parietal lobe. Another center found in the frontal lobe we talked about earlier is the frontal eye field, which is I mentioned it supplies some of the eye muscles. So this frontal eye field is supplying the ipsilateral oculomotor and the contralateral abducens nerves throughout the medial longitudinal fasciculus. So an infarction in this area, for example, involving the frontal eye field will lead to deficiency or damage to the ipsilateral oculomotor nerve. Okay, so the eye will be deviated toward the left side here. Will be deviated to the left side as the ipsilateral abducent nerve is more deviating the eye towards its side, and this by the contralateral, by the medial longitudinal fasciculus will transmit a signal to the opposite eye to be deviated throughout the other oculomotor nerve in this side. So the eye will be deviated both toward the side of the lesion, to the left side in this case. And also, one final or rare representation is the involvement of the cerebral or the visual cortex partially. This is the internal carotid artery, this is the middle cerebral artery, and these are some branches. It has two main branches, MCA, superior division, and it has inferior division. So the superior division is responsible for what we talked about earlier in the MCA syndrome. So the paresthesia, weakness, facial drop, and the visual frontal eye field, the gaze deviation toward the lesion. So in rare circumstances, the inferior division may be involved, which will lead to visual cortex infarction that will lead to homonymous heminopsia without macular sparing. Now we'll be talking about the last cortical artery, which is the posterior cerebral artery stroke. It supplies mainly the visual cortex, and its manifestation is usually limited to the visual manifestations. So PCA involvement or infarction is usually manifested by visual signs without sensory or motor involvement. And its manifestation, as we said before, it will be homonymous hemanopsia with macular sparing. As you see, the macula is spared here due to the supply from the MCA. So here, the interruption or the infarction in the visual cortex right here at the number 7 here will interrupt the signals coming from the lateral left and the medial right retinal parts. So these parts are responsible for the temporal side of the visual field, from this lateral or temporal side of the visual field. So any signals or any light coming from this visual field will fall into these two medial or lateral of the left eye parts of the retina, and will be transmitted throughout the optic tract, and it will be cross over at the optic chiasm and then passes through as the optic radiation and until it reaches the optic cortex or the visual cortex. So interruption of this at this level will damages this transmission, and the patient will present with contralateral homonymous hemanopsia. So if the lesion in the left side, the patient, we will not be able to see the right visual field, while if it's in the right side, the patient will not be able to see the left visual field. We've done talking about the cortical strokes completely, and subcortical strokes will be discussed later on separate videos. and thank you.